Hello and welcome everyone to the Menopause Symposium, where we bring you new insights from the world of menopause every month. My name is Basil Wata. I'm a gynecologist and a menopause specialist in London, and I'm joined, as always, by my friend and colleague Vikram Talaolikar, who is a menopause specialist at University College London. We hope to be bringing you these symposium once a month. Where we find an interesting article and critically appraise it and share it with you. Equally, if you have any specific new studies or articles you'd like us to review, please do share that and communicate with us in the comments or via on our websites via our email. So, Vikram, what study we have today?
So today we are discussing again a randomized controlled trial, and that was comparing a sham laser with CO2 laser, and that's for treatment of vulvovaginal atrophy or genitourinary syndrome symptoms in women who have had treatment for breast cancer and are receiving aromatase inhibitors. So this is a very peculiar and very specific group of patients having had breast cancer treatment on adjuvant therapy with aromatase inhibitors, in whom we are trialing out the CO2 versus sham laser, and that's the randomized clinical trial.
Indeed, and I found it quite an interesting study published in JAMA recently because there's been a plethora of these trials evaluating the whole
Indeed.
concept of laser used to address vaginal atrophy in the menopause. And perhaps we can discuss a little bit the background of how is this laser principle supposed to help women with menopause?
So a little bit about why the trial might have been important. Of course, this is, as I said, a specific group of patients, and the genitourinary symptoms tend to be more severe for women who have had sudden menopause, for example, after chemo or after any other medical treatments for other cancers, but more so if they are on tamoxifen, on aromatase inhibitors. Even the last drop of estrogen there is being blocked from having action on the vagina. And so therefore, the symptoms tend to be much more severe for this group of women as compared to somebody going through a natural menopause. Now, laser has been, as you rightly said, been in sort of clinical practice. It has been tried over the last many years, almost a decade. And the whole sort of theory is that whenever you have a device that's inserted in the vagina that applies laser to the vaginal wall, it will cause a sort of controlled thermal injury. An injury in the sense that it's a positive injury because it causes remodeling of the lining of the vaginal skin. It stimulates the production of collagen. It changes the blood flow to the area and how the skin and then reforms itself and how much secretions and moisture there is. And the treatment usually is monthly sessions, and which are usually can vary between 2 or 3 up to even 6 months and sometimes even more. At the moment, this is a treatment that's mainly offered in the private sector, in the UK, for example, because again, we are waiting for a good efficacy demonstration from trials. But that's the background. And there are various types of laser. Today, we are discussing CO2 laser and comparing it to sham, which means there will be no laser treatment when you use sham control. But over to you, Basil, to give the
Yeah.
nitty-gritties of the trial.
No, you're spot on, and I was interested in this because, again, as I said, there's been quite a few, and easily some meta-analyses reviewing this, and I think there's a lot of small study effect where we're not sure about, how reliable these RCTs are, and then different types of lasers. But the key specific area where I think this is of value is because it particularly could be beneficial to women who had cancer who are unable to take HRT. So let's see if this treatment is actually helpful. So they did a double-blind sham-controlled RCT with two parallel groups, and so the interesting element in this, as we can see, is that they randomized 84 women. Now, both groups had what they called first-line therapy. And this first-line therapy contained non-hormonal moisturizers, both in the vagina and externally, as well as using a vaginal vibrator twice a week for 5-10 minutes each with an intimate lubricant. So it's an interesting recipe in terms of what is a first line therapy. And clearly, I think it's important because the debate is how ethical is for you to give only sham and leave someone with no treatment at all in this
Mm,
situation.
mm.
It's not an easy decision to make. So I I think it's a quite a valid design. And so the inclusion criteria, as we alluded already, is that they were survivors of breast cancer who are taking aromatase inhibitors for more than 6 months, and they do have vaginal or genitourinary symptom with this dyspareunia and a vaginal pH of more than 5, and are willing to be sexually active. Now, the exclusion criteria is obviously if they use osyntophen, if they used any HRT or any other active treatment for the atrophic vagina, or if they had a cancer of the cervix, vagina, or the vulva, as well as any active STD or organ prolapse. So I think, what do you think of the inclusion? I think that's
I
fairly
think
fairly
robust,
valid.
yes.
Yeah.
Yeah.
So what in terms of the intervention of procedures, so CLT, means carbon laser, and SLT means sham treatment. And basically, they give 5 sessions over 1 month. So relatively short period of intervention for us to see a lot in terms of improvement. And they delivered this laser by a practitioner who's trained for it. And they describe a very well systematized way, which is reassuring in terms of ensuring there's no performance bias in the trial across all the individuals or the participants. And they used it in a 360 fashion where possible. Where it wasn't possible, it was too large, they used it in a 90-degree probe. So I think they were fairly consistent in applying the same protocol and same procedures to the whole study cohort. Don't know if you have any comments on these. Do you see this procedure being done in private practice? Is it easy to deliver, you think?
I haven't done one, and I have no idea how they are done, Basil. That I mean, theoretically, yes, you have read about it, and you kind of see diagrams, but in reality, I haven't done any.
It's quite interesting. We'll see if it works or not. And so, primary outcome is female sexual function index, and I think this is a fairly well-established scale, and it's been validated over and over again. So, something that makes sense as a primary outcome. And again, they measured other important outcomes, including dyspareunia, quality of life, vaginal health index, again, a scale which was not validated. And they also applied some objective markers. So these are the pH, the vaginal maturation index, which is relatively novel. I've not come across it in many trials, where they take a cytological sample from the vagina and expose it to cytological assessment. And they give a score from 5 to 25, with higher scores, indicating better vaginal health. They also looked into the thickness of the vaginal epithelium. And again, they took mucosal samples and they looked into how thick it is. And the closer, the higher, and the thicker, the better it is. So quite an interesting take in terms of what
Yeah.
outcomes they measured. I don't know. Do you think we should have measured any other outcomes in addition to the?
No, I think, to be honest, I mean, this is quite good because I think it has done a lot of extensive outcome measure here. You have the subjective ones, but also the objective ones.
Mm,
You could criticize each one of them, how much evidence they have. Some are better than the other. But it kind of, I think the effort you can see was to actually address some of the shortcomings of the previous trial,
correct.
trying to be as transparent and sort of bias free. So I really liked when you sent me the paper and I actually had a look at these outcomes measures. I said, this is really good because it's trying to overcome the shortcomings of previous ones.
100%. And I think it's always a challenge in a trial when you're relying solely on patient scales.
Yes,
They don't, you often lose a lot of statistical power. And then even if they're validated, they're not always reproducible. So I think adding some objective outcomes is helpful to increase
always
confidence in
useful.
the trial.
Yeah.
I agree. Um, I was a bit disappointed with the statistical analysis. They applied what I would call, as a trialist, somewhat a basic sort of analysis. They just use standard paired sample t-test and Fisher exact test. And obviously, clearly, the limitation of these is that you don't adjust for many of the variables that you would in potential confounders and factors in those response, what you would see usually in an efficacy trial. You would hope the randomization would resolve some of these, but I think more effort could have been done in terms of the statistical analysis. The impressive bit is that they've done quite good blinding, and that only the operator knew whether it's sham or not, and they tried to exclude any visual or auditory stimuli that could break the blinding of the intervention. So that was quite impressive in terms of how they've done it, and I think they've done a good job on that level.
Would have taken a lot of effort in the clinics, isn't it, to set things up and
Right.
actually run them at the time.
Yeah, 100%. So looking at the results, I think everyone is, waiting for this. So they had 84 women randomized, but only 72 completed the trial. They mentioned that this is primarily due to COVID effect, which, this trial was done
Of
in the
course.
peak of COVID, which is understandable, but still it slightly undermines the results. Overall, the interesting finding is that they saw improvement in both groups following just the first line intervention, which is really
Yeah.
interesting, that just using a non-hormonal moisturizer with a vibrator has led to significant improvement from baseline at 6 months. And even when they excluded those who are not sexually active, there was no major difference. I don't know, were you expecting these results?
Yes, because we usually recommend non-hormonal first-line therapy for all women, say post-breast cancer, if they have vaginal symptom. And many will actually find it's efficacious, it's safe, and they continue with non-hormonal intervention. So in a way, this was to be expected, according to me.
Yeah, I agree. And then when they looked at 6 months, there was basically no difference between both groups for either the primary outcome, which is the sexual function index, or for any of the secondary outcome. They were all similar across both the sham and the active laser intervention groups, even when adjusting for those that are not sexually active. So it's quite interesting. Again, not very surprising, but it goes to show that I think we still need a bit more evidence before we all buy into this laser treatment. There were no major differences in terms of the baseline characteristics, and even specifically with the objective outcomes, there were again no differences between both groups. They did comment that the laser treatment was, acceptable, safe, and very well tolerated, which is interesting because, again, doing an intravaginal treatment is not always nice and welcome by all patients. Specifically, if someone's suffering from atrophy, they might find it quite a painful process.
Yes.
And they also measured, I did not really get the logic behind this, but they measured the estradiol levels, and they were trying to see that the cancer did not boost the estradiol levels in those cancer survivors. I guess it's a good extra thing to do, although they're not particularly any mechanistic effect that you'd expect the laser to increase the estradiol. So what do you think the limitations of this?
Yes, I think in a way, as they summarize in the paper, is that it is there was loss of follow-up. So of course, the original numbers all could not complete the study. Selective cohort, although it's a limitation, I think it was the purpose of the study really to study this group. So I wouldn't say it's a limitation. The more important point is you can't generalize the findings of the paper to say women having natural menopause and genitourinary symptom. Maybe they might have some benefit from laser, which is not there in this group because they have very severe vaginal atrophy. So in that way, yes, results are not generalizable, but actually it is a selective study. There was no control group, which we understand. All groups had some active treatment. And again, there goes your point, is you can't leave somebody with terrible symptoms without any treatment, really. Ethically, how right that would be questionable. And then I think you mentioned about non-validated outcome measurement tools. Some of them are new tests which they've been specified in the paper and in fact have been put forward as something that could be used for future studies. And you're best at judging this, Basil's analysis did not sort of adjust for confounders
Yeah.
with the methodology.
I think it's just that the limitation is that often you might finding that your confidence intervals are a bit wider than what you'd hope them to be, and if you adjust, you'll have a bit more sort of confidence in your results. But again,
Mhm.
it is what it is. So, as a conclusion, I think this trial is adding to the pile of evidence showing that the theory that laser works is still yet to be proven.
Yeah.
While I think we are aware that some trials out there are proving that there is some benefit in the laser, I think perhaps, I don't know what you think in terms of future research. I think that we need to be a bit more selective in terms of which populations might benefit and which not. And also,
Well, yeah,
go on.
carry on. Yeah, I might be criticized, Basil, to say that I kind of stick robustly to evidence in a good way, or sometimes not very useful for some purposes. But I think overall, the heavy sort of message coming out through most studies is there is no efficacy proven
Yeah,
with laser. So unless we have better research studies which show any evidence, we shouldn't be recommending it for patients.
I agree.
If future studies can show there are specific subset of women where it's applicable and it has a different result, which is good, then yes, perhaps it would be an option. But right now, I think the negative research is more than the positive research.
I agree. And that's why I think there's probably room for an IPD meta-analysis because most of these trials are small and they suffer from small study effect. And so if we're able to, pool all this data across all these different trials at individual patient level data, we will have more power to really elucidate where is the
Mhm.
true treatment effect, if it's actually negative or positive,
Okay.
rather than keep doing these smaller trials. Because I think most of these trials are pharma funded. This one was not. It was actually publicly funded. So it's unlikely that a major big 500 plus RCT will come along with these. But
Yeah.
we'll watch the press and we'll definitely bring it back to the symposium if we find anything more exciting.
Definitely. So again, good negative study, and we have to always applaud these studies because positive results often get more attention, more kudos. But actually, it's equally important to do studies which show a negative effect so that we are not recommending something without evidence. So well done to the team. There are pros and cons of the study, but we've identified those and unless the future trial changes the conclusions of this trial, at the moment, this would not be a standard recommendation.
I agree. I think the take home message is not to be recommended in clinical practice yet, but watch the space. Maybe few more future RCTs might change the trend towards more beneficial impact.
Yes.
Great. Thank you, everyone, for joining us for this symposium. We are waiting for your comments and questions, either down in the comment section or over the website, and hoping to see you next time. Thank you very much, Vikram, for today.
Thank you, Basil. Thank you so much.
See you.